Okay, we have been sent another case to evaluate. Um, this is for a patient who is missing tooth number 6 and 7 and number 10 and 11, the upper right laterals and canines and the upper left lateral and canines. So one of the things that we do know is that adjacent implants in the anterior segment becomes cosmetically difficult due to papilla heights, bone spacing, implant spacing required for that. So we often look at cantilevers as options in the anterior segment. So the note that was provided to me for this particular case was I thought this may be interesting. Woman 56, low aesthetic demands, low lip line, wearing an old ugly metal RPD since she was a teenager. She was congenitally missing 6, 7, 10, 11, and she finally wants to get rid of her partial and bury it in the backyard. Challenging case due to atrophic bone, thick gingiva, of course no papilla, as teeth never developed. I thought about doing 2 long implants in the canine sides, then cantilever the laterals off. This case may be above my level. I tried to treatment plan anyway. She refused to go out to an oral surgeon even though she understands it may be in her best interest. Says she will just get another RPD. If there's a remote chance I can do this, I will bring her back for photos, CEREC scan, and study models. Take care. So, a couple of great things I read in this. One is that we're trying this, we're pushing our limits, we're planning the case, and everything. So that's always great. A couple of things that I read in that I don't like. One is if I can do this, then I will get the patient back for photos, CEREC scan, and all that. So my suggestion is anytime that we believe we're going to do a case or want to truly plan a case to determine if we can do it, we need our CEREC scan. If we have a CEREC at least. If we don't have a CEREC, then we need study models. We need to go ahead and know where the teeth are going to be, how the arch shape is. We need to be able to ideally visualize where the tissue is because the tissue will determine where the implant goes, the bone will determine where the implant goes, and the restoration will determine where the implant goes. And in this scenario, we only have the bone information. We don't really have the tissue and tooth information or the wax up information. So my encouragement here would be to always go ahead and grab the CEREC data. As an Omnicam user, this would literally take me 3 minutes to take whatever I needed so that I could have the data. But I don't want to dwell on that. So let's go ahead and take a look. This is an XG3D scan. It looks very nice. Again, I would maybe look at patient positioning here, as we typically don't see the smiley face right here. So I would reevaluate patient positioning with my team members. And there's one other thing that I wanted to point out in the scan, and that is we look like we have quite a bit of movement right here. So as I go through this volume, you can see right here that suddenly these teeth look like they're moving. So there's a good chance that our data is inaccurate and or we have had movement in the scan which can lead to inaccuracies. So again, I encourage us to teach our team members how to position our patients correctly and also how to evaluate these cases to see if there's any movement because now to be truthfully honest with you, it would be impossible to use this data to fabricate a surgical guide and to truly accurately assess whether or not this case can work. So just a few thoughts there. Now let's go ahead and jump to our plan here and let's start with site number 6. If we take a closer look at this. So as we take a closer look here, one of the things that gives me, again, without the information, I don't know the bone level position, but based on what I'm seeing here, I would definitely say that we need to go a little bit deeper than where we're at right now. The other thing that sticks out to me in this particular one is in looking at the axial view here, if we look at, if we adjust this so that we can see it, we can see that our implant is quite a bit buccal. And what that's going to do is really create an emergence and aesthetic issue for us. So if we take a look here closer, what we can see here is here is the outline of the buccal contour, the lingual contour, just like so. And while we're at it, we can take a look at number 11. So this implant would probably need to be somewhere right about here. And we'll get to number 11 in a second because there's quite a few things that I'm concerned about there. So as we can see, we're too buccal. So what I would recommend doing, and again, remember I always start with ideal and then choose to compromise, is I would probably move this implant in quite a bit like so. And then maybe I would move it like this. Again, I'm guesstimating here because I really don't have any type of true data to be able to go by. So based on what I'm seeing here, suddenly to achieve a pretty nice result, this case has just gotten a lot harder. Um, so it's a totally doable case, but this is one of those cases where I would definitely want to graft prior to placement, where we can graft this entire area right here, gain the bone width that we need, and then come back and place the implants into the site. I don't believe this would be a case where we could place the implants and graft at the same time, again, based on what I'm seeing here. So that would be my comments on site number 6. Site number 11. My first initial comment here is going to be if we were to take a look at this from the axial view, what we can see here is the edge of our premolar right there. Here is the edge of tooth number 9, and that is going to be number 12. So this, if we divide this out more ideally, that would be the space for 10, and this would probably be the space for 11. So this implant needs to probably be somewhere in right here, and we are right there. So we definitely need to move this implant. And the other way of looking at it would be right here. That implant is aesthetically in a very difficult position. So as we look at this, my initial suggestion would be to distalize this implant. By doing so, we're too close to that root. So I would go ahead and do something like this. And now I think we're starting to get this implant in a more, generally speaking, more ideal position. And again, this case also would need some type of grafting work to be able to be done. Now, that doesn't mean you can't place the implant at this odd angle over here, but it's going to create some type of aesthetic, probably a pretty difficult aesthetic issue to handle. So those are my thoughts there. Hopefully that makes sense. Thank you very much.